We assume depression is treated with talk and medication, but therapy is already changing, and it's not a human driving the shift. If you stay until the end, you'll see why the future of mental health care has already begun. First, the scale. According to the World Health Organization, more than 264 million people worldwide live with depression. Anxiety disorders often overlap. Together, they account for a significant share of global disease burden. Demand for care is enormous, access is limited, and that gap invites technology. The most immediate application is diagnosis. Artificial intelligence systems can analyze not only what a patient says, but how they say it. Facial expressions, voice tone, micro-movements. Tools like SimSensei, developed at the University of Southern California, were designed to detect subtle behavioral markers during interviews. Algorithms notice patterns humans may overlook, and that's just the first layer. The next step is predictive modeling. AI platforms have analyzed thousands of therapy session transcripts to identify which therapeutic direction may be most effective. In large-scale studies, certain systems demonstrated high predictive accuracy. Deep learning models can also monitor patterns associated with bipolar disorder by analyzing behavioral data from smartphones, sleep rhythms, activity levels, communication frequency. In some studies, accuracy approached 90%. That changes how early intervention works. Treatment isn't only about analysis, it's about interaction. Chatbots have been tested as therapeutic support tools. In controlled trials, participants with depressive symptoms who interacted with AI-based conversational systems showed measurable reductions in symptom severity compared to control groups receiving informational materials. The human therapist remained involved as a supervisor. AI didn't replace therapy, it extended it. For certain conditions, conversation isn't enough. Virtual reality is being used in exposure therapy for phobias. Instead of imagining a feared situation, patients experience controlled simulations. A person with flight anxiety can gradually confront that fear in a safe, immersive environment. The exposure is structured, gradual, supervised. Research has shown high patient acceptance and satisfaction with VR-based methods. Another unexpected tool, robotics. In therapy for individuals on the autism spectrum, robots can serve as mediators of social interaction. For some patients, interacting with a machine feels less threatening than direct human contact. This lowers anxiety and creates structured learning opportunities. Technology does not eliminate clinicians, it reshapes their role. We tend to think of therapy as conversation between two people, but today, algorithms are assisting diagnosis, monitoring, modeling, and even exposure training. Artificial intelligence does not replace empathy, but it expands access and precision. The future of psychiatry isn't humans versus machines, it's collaboration, and it's already here.